This is Dr. John Martin, Chief Medical Officer of Butterfly Network, and I'm bringing to you again today another of our fireside chats with a world expert in point-of-care ultrasound and a star physician, again, extraordinaire. So I'd like to introduce Dr. Parmy Deol, who comes at us from London. Welcome.
Thank you, John. Pleasure to be here.
So tell us a little bit about your background so that those that, the 3 or 4 people that don't follow you on Twitter, who don't know about you, why don't you give some backdrop to those that can learn a little bit about you?
Okay, so I'm an emergency physician in Chelsea and Westminster. I've been practicing there for about the last 4 or 5 years. I also work as a primary care physician there, look after both our urgent primary care problems as well as our critically unwell patients in the resuscitation area. Point-of-care ultrasound has been fairly embedded into my practice, both at a patient level to look after patients directly, as well as education of colleagues in point-of-care ultrasound for the last few years.
So there are not many physicians here in the United States that do both GP practice and emergency physician. Is that common over in England, or is that unique to someone like you?
Not really common, I would say. I kind of found myself, having trained in general practice initially, really attracted to the generalism and being a generalist, and that kind of lent its way into the unorthodox avenue, if you like, into emergency care. And then similarly, point-of-care ultrasound has just allowed me to cross those 2 boundaries and also bring them together in quite a nice way. And the hospital lends itself quite well as well, because we have an urgent care center that looks after both types of patients, and we have the critically unwell patients. So like the point-of-care ultrasound aspect works across the whole board.
So it's interesting. So when you have somebody that's really sick in your office, you just plop them in your car, drive them to the emergency room, and keep taking care of them there, and move from your office to the ED.
It's a challenge, because you know this general practice, the face of general practice, has become so different now. It includes patients in community-based care, includes patients who are co-located to the emergency department, includes patients in all different settings, private healthcare settings, non-private healthcare settings. So it's such a healthcare, the front coal face of healthcare, such a heterogeneous mix. But point-of-care ultrasound seems to lend itself well wherever you have a patient. So that bit of it has always been easy. Just tweaking and adapting.
So, emergency physician has led the world, really, with the Italians, if you will, at developing these point-of-care skills. And so obviously having the emergency room doctors have this expertise is pretty common, but not necessarily so common with GPs. And I think that makes you a pretty special GP. How have you incorporated point-of-care ultrasound? What are the typical things that you pull out an ultrasound for in your GP practice?
So we have, so I do a lot of my primary care work in our co-located urgent care center, and we get lots of patients there who have primary care health problems. There might be patients who have already seen their primary care health practitioner, or that have then worsened, or have been told or advised to come to us because the healthcare problems worsen. And typically they'll be ambulant patients, but that doesn't mean they don't have pathology such as kidney stones, gallstones, infections within their gallbladder, infections within their kidney, aortic problems, chest infections. And with a kind of a department that sees close to about 250, 300 patients a day within its urgent care center, wow. It's meant that we have a big case volume, limited resources, services, doctors, where rapid diagnosis, ruling in wherever possible, and disposition to the correct service, be that an inpatient specialty service or whether that's a discharge back home, is super important. And that's really where point of care is, as far as I'm concerned, revolutionized our care there, because alongside other point of care blood tests, it means you can really make very fast diagnosis, and patients, that's what we're all about.
So if you had to rank 1, 2, and 3 of the most common ultrasounds that you do in that setting, what would they be? Would they be lung, abdomen, cardiac? What would your 1, 2, 3 be?
Yes, I think definitely abdominal ultrasound would have to be the highest. Most people often are waiting for abdominal ultrasounds in the community, or they come in with an abdominal related complaint. And often it's the examination that yields, it can be very non-specific. Examining an abdomen, you're never quite sure. Sometimes things can present in an atypical way. And the ultrasound is so real time. I mean, visualizing something is so helpful. And so kind of looking for kidneys and looking for gallbladder related problems, aorta related problems are really common. We're doing more echo in our urgent care center as well. We do looking at patients who present with some kind of younger patients that present with chest pain. And often it is a point of care of echo. So patients are advised and consented and told that it's not there to rule anything out, but as a screening tool, it's useful, and to look for anything sinister. And with the COVID-related patients, albeit we have COVID-related patients who are slightly cohorted away from our urgent care center at the moment, lung ultrasound is really coming to the fore. The other thing that we get through our urgent care center includes a lot of swollen legs, deep vein thrombosis, calf pain, that kind of thing, where we can use the point of care to look for and to rule in early a deep vein thrombosis or even a cellulitis in the leg. It's really becoming more and more, and with the ability to be able to kind of transfer between presets so quickly now, and the portability of ultrasound, you no longer have to trudge around a department that has such a big footprint. There really isn't any reason not to, provided you've got the right skill set. And we're lucky in that regard. We've got good doctors, we've got good skill set, and good supervision within departments. So it allows good teaching opportunities, and also good, and most importantly, it's good for patient care.
So do you actually still use a stethoscope?
So I know it's a little controversial. I'm still a purist, so I will still walk out with a stethoscope. And
is that for show? So you really look like the doctor now? Is that what it is, or do you actually use it?
So I still wear. I'll be honest. I tend to use it less now. There's absolutely no doubt about it. I'm reaching for the handheld. I'm reaching for the Butterfly first. I'm reaching for a scanner first, especially to look at abdomen. But that doesn't mean you necessarily completely de-skill. There are places where it's you can see the role of the stethoscope almost really unhelpful. So intensive care, for example, where you're going to get most of your findings through ultrasound. I think there's still some expectation to be proficient in your skills with a stethoscope, but they're slowly going.
It's interesting, and I think there's a fascinating way to look at it, which I've often wondered. You actually could make your stethoscope skills better by having ultrasound and having both of them, because you can immediately see what you're hearing. I have this line that I typically use, and it's, we guess with a stethoscope. Listen, I'm a vascular surgeon. I'm supposed to understand cardiac like the back of my hand, but my colleagues who I was in part of a big cardiology practice used to laugh at me when I would listen to the heart, because they, you have no idea what you're listening to, but you can actually get pretty good. But I listen and guess, I look and know. That's really what it boils down to. But I can guess pretty good if I keep balancing back and forth between the two modalities. So I think it'll be interesting to watch that transition, but I do see a world in which the primary tool, the symbol of the doctor, stops being a stethoscope and starts being an ultrasound, no matter what discipline you're in.
100%. 100%. The challenge is the transition. The challenge is convincing one side to the other. The transition, I feel, will happen either way. I can't see it in any other way. It just doesn't make any sense to practice in a way where you have to guess anymore. That just doesn't seem, and I think patients understand that. I think my colleagues understand that. So I think that will happen. I think it's just a case of getting to a critical mass, if you like, across all specialities, and having those people that wouldn't normally take it up start taking it up, and not only take it up, but be more convinced that actually it's not just a gimmick, and that you are going to get something concrete out of this.
So you obviously were very adept at ultrasound before COVID. How has the introduction of this obviously pandemic affected your use of ultrasound, affected the way you guys care? Did you prepare for this as you saw the wave coming? You know, the tsunami was coming across the Atlantic.
Yes, yes,
Did you
yes.
guys prepare?
I mean, we did our best, really. I think what we did in the emergency department was to change. I mean, initially we weren't sure of numbers. So we had a kind of pod outside, a little area where we had people go through, and then we had siphoned off areas of the department. But I think the real challenges in the initial phases came in a operational sense. How do you change your whole department to keep patients with suspected COVID cohorted into a specific area, so they don't put other patients and staff at risk, and B, make sure that you continue to treat the patients who have other medical problems in a safe manner. Once we kind of worked out those bits of the puzzle, which took some time and also some evolution and some ongoing work, we then used our ultrasound machines in those areas. So we've got kind of obviously your critical care area, but we've also got a kind of an assessment area specifically devoted to COVID, and have an ultrasound machine based there. Similarly, another one in our critical care area. And then as the evidence began to come through from China and from Italy, and from our intensive care and acute medical colleagues, we began to see that there was some role for the ultrasound, both as a diagnostic aid for COVID with pleural changes, and possibly even as a triage tool, because as we kept getting patients who we realized were what we call asymptomatic carriers, so they would have the disease but didn't necessarily have any symptoms, we found that actually you could use some of the ultrasound findings or absence of ultrasound findings to help, again, cohort them into a specific area. As that practice grew, we found that the handheld certainly lends itself to one of those areas very, very easily. And should there be a problem with the machine, you can flex and kind of use one machine in a different area. The handheld goes to another area. It's easy. You can the disinfection is very easy. You can make decisions very easy. They're in real time. We understand that there's some evidence base to it from what we've seen in Wuhan and in Italy as well. So that was kind of the first bit. The second aspect was trying to upskill your workforce in not only how to do the skill, but doing it in a safe way. So, getting enough people trained up in lung ultrasound to then, through a formal competency program, to then get the skills, to then be able to recognize and then subsequently integrate that into their decision making. And all of that's been rapid. And
so tell us how you do that. What was the context of your training? This is, for me, and probably one of the most important things, and I'll share somewhat frustrating things, is I watch all these things unfold across the country, and I've heard from places that have been very much affected by this, go through the same process of, we have a few people that know lung ultrasound. We learned that lung ultrasound was incredibly effective. We then had to hustle and train everybody to be have skilled enough and use it, because it can be an incredibly effective tool. And I'm thinking about all those places that have these moments in time to prepare, and they're preparing about all those other things except that. And somehow I would love to see kind of your message of, say, if you've got time yet and it hasn't hit you, start training now, because that's really important. And yes. How did you train your staff?
So it was it was a challenge, and I'm sure we started probably a bit too late. But if I had the benefit of hindsight, I would have started um, getting people involved into ultrasound earlier. I think there's one thing one has to do is to try and get OFE on a personal level with all of the evidence base and be comfortable as to exactly what the role is. So you know that you can introduce it safely and also that you're doing the right thing. And that involves not only yourself, but it involves key players. So we've had multiple discussions with some of my colleagues in London who have also been doing similar things across different specialities, working out where exactly it fits. And because some of the bits are new to us, often there's a bit of anxiety component about just simply rolling out. But once we had an idea and a grip a bit more of where it could be used, it was a lot easier, because then I felt the anxiety was off. I involved our radiologists within the hospital, so I made sure they were on board, and I made sure our kind of clinical director, clinical lead was on board. And then it was a case of devising a competency framework, and you can do that relatively easily, where you have X number of scans with X number of results. So you want to make sure that people can recognize safely a minimum number for the minimally competent person. That would include, so we have a minimum of 5 scans where you detect the various findings associated with COVID, and that you're able to use that. Obviously, the caveat to all this is having the infrastructure with machines. Many departments just didn't have the number of machines to facilitate anything like this. I mean, we've been lucky to some extent because we've had enough machines, but we've also had to buy more. We've bought more handhelds, and we've been very lucky in that respect. So knowing ahead, you're going to need machines in different areas. And if you can keep those certain machines dedicated to in inverted commas, COVID area, that makes life a lot easier. Once you've done that, just some simple logistics around the competency, X number of cases in a framework, and then making sure that people know exactly. I mean, there's so many videos now available on the internet, but make sure people are exactly aware of what it is that they should be looking for. And once they've done that, we have a A4 page that we record our findings on. And we've made it very clear to our colleagues and to junior doctor colleagues that this is an adjunct. It's not there to tell you you can necessarily. I mean, in some scenarios, if there is certain patterns you see on the ultrasound, patients are relatively safe to go home. But clinical still trumps, and this is an adjunct. So as long as people are clear on how they get there, how they incorporate it, and the competency bit. I think people are all for it. If nothing else, you come out of the program with a taste for lung ultrasound, and that's something they can build on. Importantly, sadly, sorry, just to finish, if that can then be also integrated into something bigger, i.e., if your vision can extend to at a college level, at a society level, intensive cares, acute medicine, emergency medicine, society level, where you're working with your colleagues to make sure that the skills are replicated across disciplines. I think, again, that's a very healthy bit of governance. So that's up to people who are leading in POCUS to establish.
So when you talked about training people, how long would you say? I mean, one of the nice things about lung ultrasound is, of all of the ones, it's actually one of the easier ones to learn.
Yes, very much so.
It's just not that hard to learn. I mean, even a dopey vascular surgeon can learn pretty quickly.
Yes.
And the patterns are pretty recognizable. Well, there's nuance to it, as we know, but if you had to say, if you took a novice who knew how to turn on an ultrasound, how long would you take them to say to get competent in at least performing the test? An hour, 2 hours, 5 hours? What would you say?
Yes, I mean, provided we had a session yesterday for our registrars, which was about 45 minutes. These are obviously not novices to ultrasound. Some of them were, but not all of them were novices. So we had a 45-minute, an hour-long kind of didactic session, if you like, on the features, how to do it, what the sheet involves. And then I'm hoping that over the next few days, because volume is not an issue, there are patients and patients. I would say over the next few days, um, the aim is for them to all complete their competencies so they can then push on and just be practicing independently. The key is making sure that they understand that this is you're signed off to do a lung ultrasound in a suspected COVID patient.
Yeah.
And but yeah, I think the didactic session for an hour or so, and then a minimum number of scans, it shouldn't take very long, few days, as long as you've got that that heterogeneous case mix. Because even now, the difference we're seeing is that you can never establish what day you're going to see the patient, day of illness the patient is going to present, and the changes vary according to the day of illness, um, and I suspect that situation is also going to evolve as the pandemic evolves as well. So there's probably going to be a first wave of teaching, the diagnostic teaching, and as we begin to learn more about the disease and how it presents and clinical findings, there'll probably be another wave of teaching, I imagine, in a month or two to see where ultrasound fits in patients, for example, that have a history of COVID and are now presenting with something else.
Yeah.
So I see that second wave coming as well. So I'm also trying to think ahead as to how we're going to make it work there as well.
Well, I think it's going to be interesting to see if there are any residual fibrotic changes in the lung. Yeah. Is it going to reflect the ultrasound differently than historically a normal one does? We've got a lot to learn there. I think you brought up a really important point, though, and that is this could serve as that springboard to really, I mean, listen, we've known for a long time that lung ultrasound is better than chest x-ray for pneumonia.
Yes.
We've known that. The data in the literature has been very clear about that for a long time. Yet we still have not made that transition to medicine's so funny like that. There's data out there that proves you should be doing X. Instead, we keep doing Y because that's our old gold standard that we hold on to. Do you see this being that springboard to finally elevate lung ultrasound to the place where it should be and then begins to permeate across to become that gold standard, if you will, for evaluating lung pathology, and whether it's COVID pneumonia or influenza or bacterial pneumonia or congestive heart failure? I think that's the next place this all goes following COVID, don't you think?
Yes, and it's an interesting point, and I was speaking to one of our very senior radiologists about this yesterday, as I was explaining what our protocol was involving at Chelsea, and her feeling was that actually radiologists themselves don't entirely, I mean, this is a bit of a blank statement, they don't feel that comfortable with lung ultrasound. You know, there's certain people that are doing it in certain hospitals. There are, I mean, for what we use it for, it's relatively straightforward. But I think the more radiologists we get on board and slightly loosen the grip that is there with the chest X-ray, that is what will translate into more of it being embraced as a whole. It still isn't there as a core skill, I think, for radiologists, and I think many of them will openly be okay. Obviously, that's again blanket because many of them do practice. I think the more it's kind of seen as routine practice for them, the less the grip will be on the chest X-ray. For the moment, I think it's still there, though.
Yeah, and I think where we're starting to see that transition in the United States is we've had medical schools now purchasing ultrasound devices for all their students. And so when the students learn ultrasound before they become radiologists, I think their perception is going to be quite different. I think one of the other important lessons, and I wonder if you've seen the same thing, is that we have this COVID bias. Somebody comes in dyspneic and has a fever, you know, they've got COVID, and you forget the fact that they could be dyspneic because they've got congestive heart failure or because they have some other pathology. Have you seen that to be a problem in your ER? How are you keeping you guys, you know, with their radars wide instead of?
Yes, it's a real thing. It's a real challenge, and I think the other thing that makes it more so is that we've seen so many asymptomatic carriers. So we've seen so many people that we've incidentally done a CT for another reason, found that the original working diagnosis wasn't there, and that all we found is COVID. So again, people are just assuming, oh, it's all COVID. Some of the as the disease is evolving, we're learning more about it. Certainly, the higher incidence of pulmonary embolism, and also the fact that, you know, if you're hypoxic and you're have a relatively A-line pattern across the lung, something's going on. It may not be COVID, but something is certainly going on. And that's translated into a lower threshold for CT scanning. But it's a real thing, and we have to be careful. To some extent, we're slightly protected because we have a control of our front door triage, which has meant that we cohort patients to a COVID area which are suspected COVID. We're trying to siphon out patients into our urgent care center who we think may be a different diagnosis, but it's a real challenge, and I think that's a challenge for all of us, just to keep our hat on.
Yeah, and I think the difficult part about all those is these asymptomatic folks who are coming in with a gallbladder problem, yes, or a
Yeah.
or a DVT or something like that, and you don't use that. I'm not so much worried about catching it from the people that you really suspect, because
Yeah.
everybody looks like they're landing on the moon with everything they're wearing. It's the other ones where your guard gets let down, where
Yes.
people are getting burned, I think. So how has this changed you and your pattern? What is this, going through this experience? It's obviously unprecedented. How has it evolved you and the way you practice medicine, or maybe the way you think about the practice of medicine from this?
I think it's been a fascinating journey so far. From seeing a department, the way it's been built, totally changed to gear towards catering to making sure patients with suspected COVID go into the right areas. So many different challenges we've encountered: anxiety, PPE, lots of concerns from staff in that respect, keeping patients safe on one side. It's really given ultrasound a real platform to really perform at every level, at triage level, at diagnostic level, and has really brought ultrasound to the fore. I think a couple of things that have really struck out to me is that it's really, without even realizing, it's broken down barriers of communication between frontline specialities that were perhaps there before. We're now working with our intensive care colleagues and acute medical colleagues in a way I've never seen before. You know, we are really, we are all in it together. We all realize that this is not going to be won by one team or another, and with sickness and with all of those things, everyone's in it together, and everyone's, you know, really keen to get things moving forward. I ultrasound wise, I see, you know, it's been an opportunity. I really hope for hospitals and emergency departments that have previously not been able to afford an ultrasound machine, having hopefully been involved and seen some of the literature that's coming out. It's given them an opportunity to acquire one. It's given them an opportunity to try and see how can we strategically work a way that's sensible from triage to diagnostics, and thought, you know what, well, people are using point of care ultrasound. Why don't we do that? Who's upskilled in our department? And if we're not, why isn't there someone? And if there isn't someone, we need to get someone. Everyone else is, you know, and doing it successfully. And I really hope that it gives a platform for those guys to perform, which I believe it actually is. I've seen it.
You know, it's interesting. I think one of the other things, and, you know, coming at this from a vascular surgeon, you know, the biggest pain in the neck for me about ultrasound was going to find the cart. You know, whereas it's not as big an issue in an emergency department that have a lot, but most don't have enough, and you're still looking for it and rolling it in there. And it always, from two ends. One, it's a pain to go find it, so I try to decide whether or not I'm going to use my own judgment. So having these handhelds that have become personal devices, that's another hurdle for people to get over. Should I have my own? And I think when you have your own, it just makes such a difference of how often you'll use it. That whole barrier, should I use it or should I, is the effort worth it, goes away. And that's a hurdle both for physicians themselves as well as departments to think everybody should have their own, and they're affordable enough so that they should. And I think these lessons will be helpful in that regard as well, don't you think?
Yes, definitely. I mean, the other thing that I didn't mention was that although people can acquire them, there are obviously governance processes for people to go through in their hospitals. And also, because people have picked up and used this, it's kind of, again, pushed through some of the bureaucracy that would otherwise hold up the introduction of a new medical device. And it's also made people kind of reflect on themselves and see, well, uh, I'm hoping with all the success that the ultrasound is bringing and all of the help and the triage and the kind of diagnostic aids that it's bringing, both at emergency department level and ICU level, people need to think twice about uh, uh, putting up so much difficulties in introducing something that is invaluable.
Yeah, it's so all of a sudden maybe the cloud wasn't quite so scary, and that
Exactly,
actually the
exactly.
security is there, and that actually it's really helpful to be able to share images, and so it makes a lot of sense. And I think that if there's nothing else that this has produced, it's certainly that. Well, let me ask you another question, more personal to you. What
Sure.
got you involved with Twitter? We'll pivot away from COVID and ultrasound, and to you personally, what got you involved in Twitter? What have you seen been the upside of being involved in that world, and what have you seen been the downside? And for old dogs like me who are not really Twitter people, convince
Yeah.
me as to why I should be involved in that world.
Well, it's interesting because I've slightly had to take a bit of a back step from Twitter myself a little bit recently. I think originally it was a great um, platform, a great tool, great place for people to link up together, a place to hear pearls of ultrasound, and a great way to meet other people and to get good reflection on difficult cases and to do some learning. And that was great for a while. I think one of the problems I feel is that perhaps it's 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 become a little bit static at that point as well. You know, we want good research output, we want good evaluation, we want more than just pearls as well. And sometimes it is easy to get a little bit trapped in that world. And I'd like to see it kind of move to the next level where, you know, where there's more good research being generated through the ultrasound world, certainly within the United Kingdom. I mean, it was, again, it's very good for getting your name out there, institutions, very good for jobs and for getting the word out there that you've got ultrasound fellowships for different institutions. Um, but, you know, there's a lot of information and it's hard to sometimes work out what's good and what's not so good. And I think people are slightly perhaps backtracking a little bit, not completely, but backtracking a little bit because they are unsure of what's exactly the right thing to know and what isn't the right thing to know. So again, I'd like to see a bit more in terms of QC, a bit of quality control of what's coming out there. And, you know, we care about what's coming out there because we want to make sure people hear the right things. So it's great in some ways, but it's also had some downsides. I think perhaps it's time to, it has its place, but there are more formal platforms to use as well.
Yeah, and you know, it's interesting. I asked this question for a couple of reasons. One of which is, I think one of the commitments we've made and why we're talking to people like you today is we see what we want to do. There are thousands and thousands of people using our device around the world, and we've created this community, and we want to create a focal point of that community where we share credible information, good
Yes.
studies, people together that share a common bond around how they're performing ultrasound, learning from ultrasound, what is the science behind it, you know, what are the white pearls, what are the black
Yeah.
pearls that
Yeah.
are there. And I think your advice is a good one because there's a lot of information in a lot of different places. And I think what we want to try to do with people like you is build that community in here. So if nothing else, you can peek in and say, what's new? This is a credible source.
Yes. Yeah.
Um,
I think
and,
that's king. That's
and
king.
we're trying desperately to be that. So we filter very much the information that's there. And hopefully with people like you participating,
Sure.
you know, as a recognized expert, you will help us do that. And so we're incredibly grateful for the work that you do. We hope that you're staying safe. How do you, when you finish your work, how do you stay safe? Do you go through the car wash yourself, walk through it on your way home, or?
Well, as long as it's a socially distanced approach to the car wash and socially distanced from, I mean, it's a pretty monotonous routine, as I'm sure it is for everyone at the moment. But you know, our government still allows us a 30-minute exercise once a day, and we have some days off, and we just, you just got to try and let off steam as best you can at the moment. There's a lot of anxiety, just general anxiety, when's the next surge, when's this going down, and when are we going to see the end of this, and all those kind of things. But generally, everyone's in good spirits.
Well, you certainly have our thoughts and prayers. We're behind you 100%. We really appreciate you taking the time to share this with us. We look forward to following your journey going forward and
Yes, yes.
and learning from everything you do. You have a very unique perspective, but a very practical one that's incredibly helpful. So thank you again, and please be safe.
I will. And you both. Thank you very much.
Thank you.
Thanks.